Hey, welcome everyone. Endocarditis. So what are the things that we need to know regarding endocarditis? It's basically inflammation of the endomyocardium. Myocardium called myocarditis. Pericardium called pericarditis. So the endocarditis is different. Why? Because there are criteria for it. So there's what are the criteria? There are major and there are minor criteria. What are the major criteria for endocarditis? Major criteria is sustained bacteremia by organism known to cause endocarditis, like strep, staph, and Hasek organism. So persistent bacteremia by Hasek, staph, strep. And then there's endocardial evidence by echo or echo. So endocardial evidence by echo, or there's a new valvular vegetation increase or change over the pre-existing. So there's a new valvular vegetation or increase or change in the pre-existing, not adequate criteria to be major. So there's endocardial evidence by echo. These are the major. These are the minor criteria. What is that? Risk factors. What is it? Like valve disease, or IV drug abuse, or it could be fever more than 38, and vascular phenomena. Like what? Like septic emboli, arterial, could be pulmonary emboli, could be Janeway lesion. So Janeway in the palm usually, and it's painless. Osler nodules is in there. It's painful in the fingertips. Or it could be immunologic phenomena, like could be glomerulonephritis, could be Osler nodes, could be Roth spots, could be renal failure. So these are the minor criteria. So how do you call it endocarditis? We call it, how do you define it? If there is two major, blood and echo, or one major plus 3 minor, or 5 minors criteria. So these are the endocarditis. Possible endocarditis: if there is one major, one minor, almost every bacteremic patient. So this could be possible, or could be 3 minor. Okay, so possible, not definite endocarditis, could be 1 major, 1 minor in any bacteremic. So what are the major you're gonna have? Bacteremia, persistent bacteremia, and fever. So this is not endocarditis, but it's possible. Or 3 minors, like you have renal failure, or glomerulonephritis, Janeway lesion, or septic emboli, glomerulonephritis, septic emboli, and fever, plus valvular disease. You can have that. It could be possible. When do you reject endocarditis? If there is a firm alternative diagnosis that explains evidence of endocarditis. Okay, reject. There is firm evidence otherwise, or it could be resolution of everything, resolve in 4 days. This rule that and no pathologic evidence, a biopsy at surgery or death. No biopsy. There's no biopsy, then you reject that. or failed to meet the criteria. Failed to meet the criteria. So what are the diagnostic steps that we want to do for endocarditis? Diagnostic steps. What are the diagnostic steps? So blood culture 3 times, 1 hour apart, no antibiotic. You do blood culture 3, 1 hour apart, plus no antibiotics. This is for subacute endocarditis. If it's an acute endocarditis, then you do blood culture twice. You do 1 now, and then you give antibiotic, and then you do follow up with culture daily. This is acute endocarditis. You do trans echo if not sure, and then you do transesophageal echo if you are sure, just to confirm it, the diagnosis of endocarditis. What antibiotics do we use for endocarditis? Let's see. The antibiotic, if it's a native valve endocarditis, then you give vancomycin. Let's do treatment. So for native valve, then you give vancomycin. What if it is prosthetic valve? What do you give? Prosthetic valve, if it's less than 60 days, then you give vancomycin, gentamicin, plus cefepime. If it is more from 60 days to 365 days, then you give vancomycin, gentamicin. But if it is the prosthetic valve been there for more than 365 days, then you give vancomycin, gentamicin, plus ceftriaxone. So this is for the prosthetic valve. Let's delete that. Native valve, vancomycin. Prosthetic valve, usually vancomycin, gentamicin, cefepime. If it's less than 60 days. If it's more than 360 days, instead of cefepime, you use ceftriaxone. This is the treatment. When do you go for surgery? Let's see. When do you go for surgery? You go for surgery if it's more than 15 mm without embolization. Okay, this is important. We go for surgery if it's more than 15 mm without embolization, or if it is more than 10 mm plus embolization, or if there is an abscess, if there is a valve destruction, or CHF, then we remove it by surgery. So that's in a nutshell endocarditis. Endocarditis, again, major criteria: persistent bacteremia echo, or minor risk factor valve disease, fever more than 35, vascular phenomena, or immunologic phenomena. What are the definitive treatment? Could be 2 major, blood and echo, or 1 major plus 3 minor. Could be 5 minor. What do you do if it's subacute? We do culture 3 times 1 hour apart. If it's an acute, you do culture twice and then antibiotics, and then you follow up with culture daily. Trans echo, if not sure if it is. Transesophageal echo, if you are sure. Treatment, if it's native, vancomycin. If it's prosthetic, less than 60 days, vancomycin, cefepime. If it's more than 365, you replace cefepime with ceftriaxone. If it's 60 to 365, then vancomycin plus gentamicin. Surgery, if it's more than 15 mm without embolization, or if it's more than 10 mm with embolization, if there's an abscess, if there's valve destruction or congestive heart failure. And that's a summary of endocarditis. Thank you so much for listening.